Background. There are very few randomized controlled trials which have compared bypass and PCI to treat patients with left main coronary artery disease, and surgery remains the treatment of choice, and it remains unclear whether PCI is non-inferior to CABG. We have had two large studies, the Excel study and the Nobel study, and there was significant controversy about Excel study between the lead, Greg Stone, and the surgeon, and I'll leave it at that and will come to it a little bit later. So what is about left main PCI? What is the big deal? It has been a surgical domain for a long period of time, and over the last 20 years, the angioplasty of left main has been increasing all over the world, and but the data is not very convincing. And if you look at the left main, unprotected left main angioplasty in the current area, more patients undergo transfemoral procedure, mechanical circulatory supports are used more often, IABP is used more often, and we have plaque modification more often happening in the left main disease. As compared to normal angioplasty, more patients in left main have MACE with death, myocardial infarction, stroke, and emergency bypass occurring in these patients. And if we look at the Nobel and Excel study, in the Nobel study, there was a clear superiority of CABG over PCI, and the graphs started diverging at about 2 years and continue to do so at 5 years. The results were entirely divergent in the Excel study. There was initial advantage of PCI, which over a period of time equalized, showing that PCI was non-inferior to CABG. But obviously, there were significant problems with this particular study. And if we look at a meta-analysis of 5 large studies, the Nobel study, we have 6-year follow-up, Syntax 10 years follow-up, Excel 5-year follow-up, Pre-Combat 5-year follow-up, and Baudiart 1-year follow-up. We see that there is not much to choose from PCI and CABG in these particular patients. What do the guidelines say? The guidelines clearly say that in patients with stable ischemic heart disease and significant left main disease, bypass is recommended to improve survival. However, in selected patients with stable ischemic heart disease and significant left main stenosis for whom PCI can provide equivalent revascularization to that possible with CABG, PCI is reasonable to improve survival. In low Syntax score, we have 1A indication. In intermediate, we have 1A level of evidence 2A for PCI, but in high Syntax score, we obviously have more in favor of CABG. All over the world these days, heart team approach should be used to see whether angioplasty or CABG would be the preferred choice. The contemporary angioplasty of left main would indicate imaging must be done in all patients. Left ventricle support, when indicated, most people would do a 7-French guide catheter to do it, and it entirely depends on the experience of the operator about what the outcome is going to be. And intravascular ultrasound is the way to go forward, and in all complex left main angioplasty, intravascular ultrasound should be done, and I'm not clear that in this study, intravascular ultrasound was done in how many patients in different centers. So this registry has looked at revascularization in all comers in Sweden, and this is the data from SCAR registry. All patients who underwent coronary angiography for stable angina, unstable angina, non-stable between 2015 and 2022 were analyzed. Patients who had STEMI or who were declined by surgeon for bypass were excluded from this registry. Left main was defined obviously as more than 50% stenosis. If we look at the methods to adjust for known and unknown confounders, they used multi-level Cox proportional hazard regression with instrumental variable, and we'll come to instrumental variable shortly. And quantiles of preference or PCI treating hospital was the treatment preference in institution, instrumental variables. In addition to instrumental variables, the covariates include age, sex, diabetes, severity of coronary artery disease, smoking status, hypertension, hyperlipidemia, creatinine clearance, BMI, prior MI, PCI, prior bypass, clip class, and the year of doing it. This is an online database, and all angiography and PCI since 1989 have been entered into this database. There are 30 hospitals, and there's about 100% coverage, and this is funded by the Swedish health authorities. If we look at the left main data, there were equal number of patients in PCI and CABG, and the primary endpoint which was analyzed was total mortality. And these are the 30 centers, and if we look at the variability, that there are centers where there is about 90% people with left main who undergo angioplasty, and another center there are 90% patients who undergo bypass surgery, and we have the entire spectrum in these 30 centers. And in that particular registry also, in the trends, if you see, the number of angioplasties for left main have been increasing and bypass going down. Patient characteristics, if we look at, there were more elderly people in PCI group, the more sicker patients, creatinine clearance was lower, and more patients had previous myocardial infarction, previous CABG, and more patients had CLIP class 2. And that is a variable we need to consider. And the results show that the all-cause mortality was higher in the PCI group, and these curves, as relative to the other studies, have started diverging immediately after the onset. And that is an area which we need to look at. And this study showed that if in the younger population bypass surgery was done, there was about an added advantage about 1.5 to 2 years, but in elderly people with a relatively short lifespan expected, there was a lifespan added of about 3 months. And if we look at the subgroup analysis, in elderly people above 80 years, PCI was better. In other patients, considering the SACS, diabetes, and STEMI, surgery was a better proportion. In elderly people, angioplasty was better. If we look at the limitation, this is an observational study, and we cannot exclude selection bias and is residual confounding despite the IV analysis. And there is no data on cause-specific mortality, and there is no data on the IVUS used in these patients. So these observers concluded that CABG was associated with lower mortality in patients undergoing revascularization for left main coronary artery disease. The benefit of bypass was highest in younger patients with longer life expectancy. PCI was associated with lower mortality in patients above 40 years of age. If we look at the critique of this registry, observation analysis, confounding variables, non-randomized sample, baseline characteristics showed sicker patient, elderly people with prior MI and prior CABG in the PCI group, and there are inherently different patients who underwent bypass surgery. Early mortality benefit with surgery needs to be seen because that's not been seen in other trials. And there's a wide variability in the treatment preference across the hospital, with lower volume center more likely to perform PCI than higher volume center. And we must remember that in studies, only 7 to 8% of people who are eligible undergo randomization because tests are rejected by the surgeon. Thank you. Thank you.
Thank you. Thank you, sir.